Welcome back to the deep dive. Today, we are really getting into a challenging area of mental health,
Mm,
the schizophrenia spectrum and related psychotic disorders.
that's right.
And our goal here, using the clinical sources you've shared, is to kind of map out this landscape, look at the beginnings, the symptoms, and importantly, the realities of the medications used.
Definitely. And I think right off the bat, we need to be super clear about one thing. Psychosis,
Yeah.
well, it's fundamentally a symptom.
Okay. Not an illness in itself.
Exactly. It's about having trouble telling what's real from what isn't. We're focusing today on conditions where that symptom is central,
Yeah.
affecting, thinking, speech, emotions, how people perceive the world.
Got it. So let's maybe put some numbers to this.
Yeah.
The sources mention a worldwide lifetime prevalence for schizophrenia of about 1%.
Yeah, around 1%, which sounds small, but the impact on individuals and families is immense.
Huge. And the age it starts seems significant, too.
It really is. It gives us clues. For men, the onset is typically earlier, average age around 19, usually somewhere between, say, 16 and 20. For women, it tends to show up later. The average is more like 27, maybe in the 25 to 30 range.
And it's usually not just one cause, right? It's complex.
Oh, absolutely. It's almost always a mix. Think inherited gene vulnerability sort of meeting uh, environmental factors or significant life stressors, especially during development. It's that interaction.
Okay, so let's zoom in on how this actually develops. You're saying psychosis isn't like flipping a switch, it's more of a spectrum, a continuum.
Exactly. You start with what we'd call adaptive responses,
Yeah.
logical thinking, accurate perceptions, behaving appropriately.
Right, the baseline.
Yeah. But then there's this slide towards maladaptive responses. Thinking gets disorganized, maybe delusions creep in, perceptions change, like hallucinations, behavior might become erratic, people pull away socially.
And this slide, this gradual phase, that's crucial, isn't it?
It's incredibly important. Clinicians call this the prodromal period. It's that time leading up to the first really obvious psychotic episode.
The prodromal period. The sources really highlight this as the key time for intervention, the best case scenario almost. So what are we looking for then? What are those early signs?
Well, beyond the more obvious things like, maybe grades dropping or performance at work declining,
Sure.
you see these subthreshold symptoms, sleep gets disturbed, there's this growing social awkwardness, maybe pulling away from friends, sometimes appearance starts to deteriorate. But what I find fascinating, and sources point this out, are some of the physical signs that can appear quite early.
Physical, like actual motor changes.
Yes, exactly.
Hmm.
Things you might observe, like a kind of blank or vacant facial expression, maybe staring for long periods,
Okay.
or blinking less often than usual, sometimes an awkward gait, the way someone walks, even subtle things that look a bit like Parkinson's symptoms, some rigidity, maybe a slight tremor.
Wow. Emotionally.
Emotionally, a big one is losing the ability to feel pleasure. That's called anhedonia.
Anhedonia, right?
Yeah. And maybe sudden irritability, getting angry easily, or just a real lack of motivation for anything.
So these physical things, the staring, the gait, is that the brain's instability starting to show physically? Like, are we seeing the dopamine system issues manifesting early?
That's precisely the thinking.
Yeah.
It's likely the early signs of that neurobiological dysregulation,
Mm-hmm.
probably involving dopamine pathways, which, control movement and expression as well as thought. So the system handling thought and perception is linked to motor control. If we, as family members, teachers, or clinicians, can spot these subtle, often overlooked physical and emotional shifts early.
Then we have a better shot at that early support.
Exactly, that's the hope. Getting support in place during that prodromal phase can make a real difference long term.
Okay, let's shift to the symptoms when the illness is more established. The sources use this key distinction, positive versus negative symptoms. Why is this division so important?
It's fundamental because it really guides how we approach treatment. It helps organize our thinking.
So what's the difference?
Think of it simply. Positive symptoms are about an excess or a distortion of normal functions. They're things added to the person's experience.
Added. Okay, like things that shouldn't be there.
Precisely. The more obvious signs people often associate with psychosis. Then negative symptoms are about an absence or a reduction of normal functions. Things that should be there but aren't, or are much less intense. Deficits, basically.
Got it. Added versus taken away. And generally, positive symptoms respond better to meds.
Generally, yes. The medications we have are often more effective at reducing those positive symptoms. Let's start there. Hallucinations are a big one.
Right. False perceptions.
False sensory perceptions, crucially, with no external stimulus. Hearing voices is the most common auditory hallucinations. But they can happen in any sense: sight, smell, touch, taste.
And you mentioned command hallucinations. Those sound particularly dangerous.
They are. These are voices that specifically tell the person to do something, often to harm themselves or someone else. If a patient reports command hallucinations, that requires an immediate, very serious safety assessment. It's a red flag.
Absolutely. Okay. Then there are delusions. These are beliefs, right?
Fixed, false beliefs, and the fixed part is key. They hold on to these beliefs no matter what evidence you show them.
What kinds are common?
Well, the sources list several, but two are really important clinically. Grandiose delusions, where someone believes they have extraordinary abilities, fame, power. Maybe they think they're a famous person or chosen by God.
Like they think they're the head of MI6 or something?
Or the Virgin Mary. Yeah, things like that. Then there are persecutory delusions.
And you flagged these earlier as often being the most unsafe. Why specifically persecutory ones? Is it just the fear, or does it lead to actions?
It's really the combination. If someone truly unshakably believes they're being spied on or plotted against, or that their food is being poisoned,
Right.
it makes trusting anyone, including medical staff or family, incredibly difficult. They might refuse food, refuse medication, because they think it's part of the plot.
Yeah, that makes treatment almost impossible.
It does. And that deep-seated fear, that mistrust, combined with the possibility they might act defensively against who they think is persecuting them. That's what makes persecutory delusions so high risk in a clinical setting.
Makes sense. Okay, let's pivot to the negative symptoms, the deficits. You said these are often more persistent.
They often are, yes. And it can be really disabling in terms of daily functioning and quality of life.
What are the key ones? I see these A terms in the notes.
Right. Those A terms describe the loss of function. So there's alogia, that's poverty of speech.
Yeah.
Very little talking, maybe just brief, empty replies.
Okay.
Then avolition. This is a lack of motivation, difficulty starting or sticking with activities, even basic things like self-care. Big impact on daily life.
And the emotional side.
Yeah, affective blunting or flat affect. It's a reduced range of emotional expression. Their face might not show much emotion or might seem inappropriate, like laughing during a sad story. And finally, asociality, which is basically social withdrawal. Reduced interest in relationships, leading to isolation. These negative symptoms often need more than just medication. Things like therapy and community support become really vital.
Which brings us nicely to the treatments. Let's talk about the pharmacology. The aim of antipsychotics generally is to block dopamine receptors, right? To calm down those positive symptoms and reduce relapse risk.
That's the core idea, especially for the older drugs.
Okay, so let's start there. The first generation, or typical antipsychotics, haloperidol is a common example.
Right. These are strong dopamine blockers. They hit those D2 receptors pretty hard. And they are effective, especially for positive symptoms. But
There's always a but.
there's a big but. Because they block dopamine so broadly, they come with a significant risk of extrapyramidal side effects, or EPS, movement problems.
DPS. Okay, these sound serious. Some are emergencies.
Absolutely. The most acute emergency is acute dystonia. Yeah. It's sudden, involuntary, often really painful muscle contractions or spasms. The classic ones are the neck twisting to one side, torticollis, or the eyes rolling upwards, oculogyric crisis. It's distressing and needs immediate treatment to relax the muscles. Fast.
Okay, emergency number one. What else falls under EPS?
Another common one is akathisia. This is different. It's an intense inner restlessness. People feel like they have to move, they can't sit still, like they're crawling out of their skin.
That sounds awful and potentially mistaken for just anxiety.
Exactly. That's the danger. If staff think it's worsening agitation or psychosis, they might increase the antipsychotic dose, which actually makes the akathisia worse. Careful assessment is key.
Right, and then there's a long-term risk.
Yes, that's tardive dyskinesia, or TD. Tardive means late appearing. This usually develops after months or years of treatment.
And what does TD look like?
It involves involuntary, repetitive movements, often the face and mouth area, lip smacking, puckering, tongue movements, chewing motions, sometimes finger or limb movements too.
And the really scary part is it can be permanent.
Often irreversible, yes, even if you stop the medication that caused it. That's why preventing TD using the lowest effective dose, regular monitoring with scales like the Ames test, is absolutely critical with these older drugs.
Okay, so that high risk of movement disorders led to the second generation, or atypical antipsychotics. How are they different?
They have a different mechanism. They still affect dopamine, but they also act on serotonin receptors. It's this serotonin-dopamine antagonism that seems to make the difference.
How so? What's the benefit of hitting serotonin, too?
It seems to result in a more targeted dopamine blockade, especially in the brain pathways controlling movement. So you get less dopamine blocking in those areas.
Meaning fewer movement side effects.
Significantly fewer EPS,
Mm.
especially the acute ones like dystonia and akathisia. They also seem to have some effect on negative symptoms, though that's debated. But the big trade-off,
Ah, here comes the other but.
right, we swap the high risk of EPS for a high risk of metabolic syndrome.
Metabolic syndrome. Okay, this is where it gets really interesting, as you say. We reduce the visible movement problems, but we gain what exactly?
We gain a cluster of internal physical health risks. Significant weight gain is very common and often rapid.
Right.
Also, dyslipidemia changes in blood fats, like higher cholesterol and triglycerides, and altered glucose metabolism problems with blood sugar control, insulin resistance, increased risk of type 2 diabetes.
So basically, increased risk for heart disease, stroke, diabetes.
Exactly. These drugs can seriously disrupt the body's metabolism, leading to major long-term cardiovascular and endocrine problems.
Wow. So we're asking patients to take a drug that might stabilize their mind but could significantly shorten their life expectancy through physical illness. That's a huge dilemma.
It is the major clinical challenge with the atypical antipsychotics. Managing these metabolic risks is absolutely paramount. Regular monitoring of weight, waist circumference, blood pressure, glucose, lipids is essential.
Essential, but maybe hard to stick with. Okay, one specific drug needs a spotlight. Clozapine. Highly effective, but lots of warnings.
Clozapine is unique. It's often the most effective drug, especially for people who haven't responded to other treatments, treatment-resistant schizophrenia,
But it's reserved for those cases because...
because of serious, potentially fatal side effects. One is that it can lower the seizure threshold, increasing seizure risk, especially at higher doses or if started too quickly.
Okay.
But the biggest concern, the one requiring intense monitoring, is agranulocytosis.
Agranulocytosis, what is that?
It's a drastic drop in neutrophils, a type of white blood cell crucial for fighting infection. It leaves the person extremely vulnerable to potentially deadly infections.
So how do you manage that risk?
Strict monitoring.
Mm.
Patients on clozapine must have regular blood tests, a complete blood count, or CBC, to check their white cell count. Often weekly at first, then maybe less frequently, but regularly for the entire time they're on the drug. They have to be enrolled in a special registry. And patient education is critical. They need to know to report any signs of infection, like fever, sore throat, flu-like symptoms, immediately, because it could signal their immune system is crashing.
Okay, shifting gears slightly. Let's talk about interacting with someone who is experiencing psychosis. How do we communicate effectively and safely?
Good communication is key. The sources emphasize keeping things simple. Short, clear sentences. Don't overwhelm them with too many questions or complex ideas.
Right. And what about the delusions or hallucinations? Do you argue? Do you agree?
Neither. Ideally, you walk a careful line. You don't want to argue or try to reason someone out of a fixed delusion. It doesn't work and can damage trust.
Okay.
But you also don't want to play along or confirm that their delusion or hallucination is real. That's not helpful either.
So what do you do?
You convey empathy.
Mm.
Acknowledge their distress. That sounds really frightening, or I can see this is upsetting for you. Try to understand the feeling behind the delusion, like the fear in persecutory delusions.
Focus on the feeling, not the content.
Exactly. And if they ask you directly, are you hearing that too? Or do you see them? Oh, you need to respond honestly but gently.
All right.
State your own reality calmly. No, I don't hear the voices, but I understand that you do, and that must be difficult. Maintain eye contact if possible. Speak clearly, maybe a bit louder than usual if they seem very internally preoccupied. Using their name can help ground them.
And touch.
With permission. And if it feels appropriate culturally and situationally, a light touch on the arm can sometimes provide sensory validation, help anchor them in shared reality. But always ask first or gauge carefully.
Okay, finally, let's talk about the longer-term picture. Recovery. The sources are clear. Schizophrenia isn't considered curable. So what does recovery mean here?
Recovery in this context isn't about eliminating the illness entirely. It's about living a meaningful life despite the illness. It's about hope, empowerment, gaining the greatest possible level of independence and functioning.
Focusing on potential, not just deficits.
Precisely. But we have to be realistic. There's a sobering fact mentioned in the material. People with schizophrenia live, on average, significantly shorter lives.
How much shorter?
About 25 years less than the general population.
25 years, that is staggering. Why such a huge gap? Is it the illness itself, the side effects we talked about, suicide risk, lifestyle?
It's likely a combination of factors. Suicide rates are higher, yes. Lifestyle factors related to negative symptoms like poor diet or lack of exercise play a role. Access to good general medical care can be an issue.
And the medication side effects.
And absolutely, the metabolic consequences of the second-generation antipsychotics are a major contributor to that reduced lifespan through cardiovascular disease and diabetes. It underlines why managing physical health is just as important as managing the psychosis.
So relapse prevention isn't just about psychiatric symptoms.
Not at all. It's holistic. Preventing relapse involves teaching people to recognize their early warning signs, maybe sleep changes, increased anxiety, feeling overwhelmed.
Feeling their triggers.
Knowing their triggers, knowing their personal warning signs, and having a plan. Reduce stress, go somewhere they feel safe, talk to a trusted person or professional, maybe adjust medication temporarily with their doctor. It's about proactive management.
And therapy.
Therapy, like cognitive behavioral therapy, CBT, adapted for psychosis, can be very helpful too. Helping people understand their experiences, develop coping strategies for voices or beliefs, challenging negative thoughts. Principles like normalization, helping them see their experiences aren't totally alien, can reduce distress.
We've really covered a lot today, from those very subtle early physical signs through positive and negative symptoms, the complex world of medications and their risks, communication strategies, and this idea of recovery.
It's a lot to take in.
It is. The key takeaways seem to be understanding that positive-negative symptom structure and really grappling with the risks versus benefits of the medications. Early, informed recognition seems crucial. Which leads us to a final thought for you, our listeners. The sources strongly suggest that catching these issues early, during that prodromal phase, offers the best chance for a better long-term outcome.
Definitely the best case scenario.
But those early signs, withdrawal, blunted emotions, maybe some odd behaviors, are exactly the kinds of things that often face huge social stigma. People get judged, dismissed, or families might be afraid to seek help.
Yes, stigma is a massive barrier.
So the question to mull over is this. If stigma is actively preventing people from getting help, precisely when it could be most effective during that critical early phase, what does tackling that stigma really mean for changing the trajectory of these illnesses? How do we overcome those social barriers to actually improve lives on the spectrum?
A really vital question, something for all of us to think about. Thank you for joining this deep dive today.